Hello, my name is Arne Bleijenberg. I'm a PhD student in the Amsterdam University Medical Center. And in this video I will tell you about a recent publication in Endoscopy, which was entitled Implications of Different Surveillance Guidelines After Serrated Polyp Resection in the United States and in Europe. We know from previous studies that patients with serrated polyps are at increased risk of developing colorectal cancer or serrated polyps later on. And that's why it's globally accepted that patients with serrated polyps should be surveyed after several years when serrated polyps are resected. International guidelines are very consistent in their recommendations of the optimal interval surveillance after resection of adenomas, for example non-advanced or advanced adenomas. But when it comes to serrated polyps, there are substantial differences between the international guidelines, and most notably between the European and the American guideline. This difference is mostly a result of the fact that serrated polyps can be subdivided into three subclasses. And of these three subtypes, the hyperplastic polyps and the sessile serrated lesions are by far the most common ones. Sessile serrated lesions are thought to harbor malignant potential, while hyperplastic polyps are generally considered benign. And the United States guideline uses this knowledge to stratify their surveillance. So patients with only sessile serrated lesions are surveyed more stringently than patients with only hyperplastic polyps. But the problem is that this requires accurate and reliable histopathologic diagnosis or discrimination actually between hyperplastic polyps and sessile serrated lesions. But when looked upon under the microscope, it is very difficult to discriminate hyperplastic polyps from sessile serrated lesion. And as a result, the histopathologic discrimination between these two subtypes of polyps is in fact not so reliable at all. So what should endoscopists do when they cannot rely on the histopathologic discrimination between these subtypes? Well, one way is not using the subtypes to stratify surveillance. And that's exactly the strategy that the European guideline offer. So they treat all the serrated polyps identically. They only look whether they are larger or smaller than 10 millimeters and whether or not they harbor cytologic dysplasia. Now in our study, we used prospectively collected data from over 5,000 primary screening colonoscopies to simulate two scenarios. In the first scenario, we calculated for each individual what the surveillance interval would be when the American guideline would have been used. And in the second scenario, we calculated what the surveillance interval would be if the European guideline had been used. And then we measured the degree of overlap between these two strategies. And in the 5,323 colonoscopies that we could include in our database, 98% of the patients would receive exactly the same surveillance interval according to the American and the European guideline. So the difference was actually very small in clinical practice. And we also looked at the subgroup of patients that had one or more serrated polyps. And then still, we saw that 90% of the patients would receive exactly the same surveillance interval following the American or the European guideline. Based on these results, it seems that despite the different approaches, American and European guidelines lead to remarkably similar clinical outcomes in daily practice. And in turn, this means that when we determine the optimal interval for surveillance after resection of a serrated polyp, we do not necessarily have to take into account the serrated polyp subtype. Because after all, we show that from a patient perspective, apparently the difference is not that large. I want to take this opportunity to thank all my colleagues and co-authors that have helped throughout the study, and I want to thank you for taking the time to watch this video.